Hello, my name is Brian Helfand, and I'm a urologist at North Shore University Endeavor Health in Chicago. And I would like to start by thanking the PCRI for the opportunity to speak today about a topic that is near and dear to my heart. And that is, I think, a very exciting topic in the field of prostate cancer. That only continues to get better and better over time. And that specifically is the topic of using genetic testing for making prostate cancer decisions. So today, I would really like to address, should every patient get a germline genetic test along the prostate cancer journey? I'd like to just disclose that I am an advisor and a speaker for GoPath Diagnostics, which is a genetic testing company in the field of prostate cancer. And certainly, when we start talking about genetics and genetic testing, I've always found that a lot of people go to sleep, and that's just because we are so used to the concept of genetics in our biology classroom when we were just trying to get through the day in high school. But it turns out that genetics itself has become and it always probably has been, a very, very exciting field. And certainly the use of genetics has only increased, and that's just because of the technologies that we've used to uncover and get genetic testing have become more advanced, more sophisticated. So we can sequence now everyone's DNA from start to finish. And that cost of that, which used to be thousands and thousands of dollars, we can do at very, very inexpensive fees. So because of that, genetics has really exploded, and its utility in making decisions within medicine and all aspects of medicine has only increased. So today, I'd really like to start off with the basics. And that is really talk about some of the genetics and then ultimately how we use that along the prostate cancer journey. So when we talk about genetics, it's a large field, and there are many, many different aspects to it. But specifically, we're looking at DNA. And again, just to remind everyone, that is the substance in every single cell that is ultimately passed down from generation to generation. And that generational type of DNA is something we call germline. Okay, and again, that is in every single cell of your body, has the same copy of your DNA. And that's what makes you unique, and other people unique to themselves. And again, every single cell that is normal in your body has the same germline DNA. On the other hand is sometimes we are exposed to toxins, or we're predisposed to form tumors. And as those tumors start to divide, their DNA within those tumors starts to change. Okay, and we talk about tumor DNA a little bit differently than we talk about that DNA that's passed from generation to generation. So that tumor DNA is known as somatic DNA. And that also is really unique to every single tumor, but it certainly has the ability to be different than the germline DNA because it's acquired mutations. So as an example, if a patient has a DNA that has codes of what I'll call A, B, and C, and then that person is exposed to the sun, and the sun hits the skin, and in a certain part of the skin, there are mutations accumulated, and those the DNA is now ABD sequence. That ultimately those ABD sequence cells are called somatic changes or tumor changes and are unique to that tumor, versus the ABC DNA, which is passed from generation to generation, is in every other part of the cell that doesn't, every other part of the body that doesn't have that tumor. So that's really kind of the basis here, is that what we're really talking about today is germline testing. That is the stuff that's in everyone's body. We are not specifically talking about tumor DNA changes or somatic changes. That is the subject of a different lecture that we hopefully will give at a later time. So germline DNA is really, really important. And as I said, is that we now have the ability to use DNA tests to better understand that DNA that we bring with us that is in every single cell. And by understanding that, that can give us insights into what is the risk of us developing certain diseases, just like prostate cancer. It may give us insights into, are we predisposed to a more aggressive type tumor, something that may need treatment? It may give us insights into what other type of related cancers or diseases we may be at risk for. And so it is a very important piece of our DNA to understand. And historically, all we really used to understand our germline genetics, what we were inherited, was family history. And family history remains the gold standard. And that's just because, number one, it's cheap. You don't need any test to understand family history. But it was historically the only tool that we had. Did your parents have a certain disease? Did they have a risk of heart attacks? Did your father have a risk of prostate cancer? And so certainly if you had a risk of that family history, we want to know that because that does increase your risk of being diagnosed with a certain disease. And in prostate cancer, we do know that family history information is really important, right? So that if you have a father or a brother, what we call a first-degree relative who's had prostate cancer, your risk of developing prostate cancer is higher. Specifically, if your father had prostate cancer, your risk is about 1.5-fold that of the general population. So it's higher because your father had prostate cancer. And the more relatives you have that same history of prostate cancer, the increased risk. So if you have two relatives, your risk is about 2.2-fold higher than if you had no relatives that had that family history. And again, family history has historically been not only the only tool, but that's all we've had. What we've learned throughout time is that family history is limited. And that's because of several reasons. Number one is that if you have a family history, you may not know it, especially as a male gender. We may not understand who had it. We don't talk about a lot of it. And so if we were ignorant and didn't gather that ahead of time or didn't have that opportunity to talk to our family members, it may be there. We just didn't know about it. Additionally, it can change over time, right? My father didn't have prostate cancer, but tomorrow he goes to the doctor, he's diagnosed. Now all of a sudden I have that risk. So it can change over time. So ultimately, family history is still important, but it's not the most reliable. We still recommend, and it is very important when you're looking to assess a person's risk of developing a disease, obtain a family history. Throughout time, we've also been able to test our DNA, test our germline DNA specifically to look for specific DNA alterations that we call mutations in certain genes that ultimately can predispose to a certain disease, including prostate cancer. These mutations are generally considered rare. Okay, so we actually refer to them as rare pathogenic mutations. And these occur in a lot of genes that make the media. So breast cancer, as an example, has really highlighted certain genes, including BRCA1, BRCA2, that have become really more of a household name, if there is such a thing. So those BRCA genes themselves have been known to increase your risk of breast cancer, ovarian cancer, et cetera, and they alter a lot of decisions that women make around screening and treatment, even prophylactic treatment, regarding breast cancer. It turns out that those genes, along with some others, are also very important in prostate cancer, and we should test those genes to see if you have those mutations to see your risk of prostate cancer. So again, part of an important genetic assessment in germline DNA testing. The newest part to the scene is something that we call single nucleotide polymorphisms. So these are not mutations in a gene, but these are variations throughout everyone's DNA. And I'm going to talk subsequently specifically about what they are, but we can count the number of these SNPs or these little variations throughout everyone's DNA that are specifically associated with prostate cancer and create a score called a polygenic risk score that estimates a man's risk of developing prostate cancer. And so when you look at a true genetic assessment for prostate cancer as an example, you can look at the relative importance of all of these components of a genetic history. Family history can explain about 7% of the heritability of prostate cancer. It's important that we assess it, but again, it doesn't really explain the whole story. When we look at those rare pathogenic mutations, such as BRCA2, et cetera, that's about 2% of the population of men who ultimately develop prostate cancer. And finally, if we look at a polygenic risk score, that at its simplest explains about 20%, but that can be up to 40% of the reason why men develop prostate cancer. So as I said, we're going to touch throughout this program a lot on polygenic risk scores. And again, polygenic risk scores is just a score that's created by looking at the presence of single nucleotide polymorphisms, or SNPs. Again, every cell in your body will contain these SNPs or variations. Again, the easiest way to think about a SNP is that they are blips or variations throughout everyone's DNA. And if you look at everyone's DNA, there's about 10 million SNPs that exist within the human genome. So these are interspersed throughout the entire DNA and genome that any individual has. And there are certain combinations of these SNPs that have been associated with specific diseases, meaning that there's about 300 or more that have been reproducibly associated with increased risk of prostate cancer. There are others that are associated with breast cancer. There are others associated with colon cancer and heart disease and things like osteoporosis, and you name it, that there's usually a combination of SNPs that can be used to create a score that can be used to estimate a person's risk of any disease. And for prostate cancer, these can explain over 40% of that heritability disease risk that we talked about. So it is a very important part of that genetic assessment to realize that they not only exist, but to be used potentially along that prostate cancer journey. So as mentioned, we can use those SNPs to create a polygenic risk score. And that it sounds like a whole mumble jumble. But what a polygenic risk score is acknowledging and testing a patient for these SNPs, looking at how big of an effect the SNP has, meaning that if you have a SNP, how much risk does it actually impart to prostate cancer? So you can count up the number of SNPs that any individual has, take in account their effect size, and then put all that into a fancy mathematical equation to create a score known as a polygenic risk score. And we've tried to make this easy for clinicians as well as patients to understand it by creating a specific type of polygenic risk score known as a genetic risk score. And basically, a genetic risk score makes it so that anyone can understand it. And so if you have a genetic risk score equal to a value of 1, that means that you have average population risk. That means that the number of SNPs that you have are average. And that means that your risk of prostate cancer, an example, is the average in the population. As an example, an average white male in the US population has about a 1 in 8 lifetime risk of being diagnosed with prostate cancer. If you had a score that was higher, so a genetic risk score that was, as an example, 2, that means you're twofold higher or double that risk. So that individual who had a score of 2 would have a score of 1 in 4 chance or lifetime risk of being diagnosed with prostate cancer. And if you had a genetic risk score value that was lower, about 0.5 or 50% less, that individual would have 1 in 16 chance of being diagnosed with prostate cancer throughout the lifetime. So again, we can use these genetic risk scores to really tell a patient what is their lifetime risk of being diagnosed. And this is just to show you that I'm not making this up. This concept of using genetic risk scores or polygenic risk scores have been utilized in many, many studies and that involve hundreds of thousands of patients, both with prostate cancer and without prostate cancer. And as you can see here is that there's a spectrum that's generated, right? So on one hand of the spectrum, you may have an individual who has almost a 6-fold higher risk of being diagnosed with prostate cancer. That patient is at high risk of being diagnosed. And so we would envision that that person should probably be screened early or more frequently because they have that inherited risk that can be used. On the other hand, on the other end of the spectrum, there are patients who have 80% lower risk of being diagnosed with prostate cancer, and therefore they're a lot less likely to be diagnosed. And so we probably can temper or de-intensify their screening practices. And again, just to compare it to what would be still considered the gold standard, is that we use family history. And family history itself, really, do you have a father with prostate cancer or not? And if you have that positive family history, it only imparts a 1.5-fold risk, and that's to every man who reports that family history. So when you look at something like genetic risk score, it is a lot more informative because it really is personalized to what your risk is, but it really spans that spectrum, and you can envision how that can help you make a more informed decision, especially if you're in this, you haven't been diagnosed, you're unaffected, so to say, with prostate cancer, and you're undergoing prostate cancer screening. So now that we know the basis of genetic assessment, including family history, including rare pathogenic mutations, including the polygenic risk score, how can we use that along the prostate cancer journey? So as I said, is that this can really be used in the diagnosis, right? So when we take unaffected men who are undergoing screening, can we use genetic testing, all of those components, to identify men who are at high risk of being diagnosed with prostate cancer? Every single authoritative guideline that we have out there all recommend earlier and potentially more frequent screening among men high risk. Can we use genetic tools to identify those populations that are of highest risk of being diagnosed with prostate cancer and potentially even aggressive disease? Can we use genetic assessment for prognosis? If a patient is newly diagnosed with prostate cancer and he seemingly has a lower risk, less aggressive type tumor, can genetic testing help us identify those patients who actually will go on to develop a more aggressive or metastatic cancer? Can it help us guide in that setting? Can genetic testing, once a patient has advanced prostate cancer, meaning that it's spread to lymph nodes or bone, etc., can genetic testing be used to identify those patients who are most likely to respond to specific chemotherapies or radiation therapy? And finally, can genetic testing be used not only for the patient, but also their family members to help screen better? Meaning that if any of these genetic tests not only increase your risk of prostate cancer, are there other insights that can be provided because they have higher risk of developing other type of cancers? As an example, if you have a BRCA2 mutation, we know that you have increased risk of prostate cancer, but it also imparts increased risk of other tumors, including breast cancer, ovarian cancer, pancreatic cancer, et cetera. And knowledge of that can help us better screen those patients and their family members as well. So to go through this a little bit more detailed is, can we use genetic testing to assess the risk for unaffected men, identify those high-risk populations, and help us improve our screening behavior? And so again, we've talked about family history, and that's still the gold standard, as to say, if we use family history, we identify a high-risk patient. Yes, it is recommended that those patients start earlier testing. When we then switch to something that is a little bit more nuanced, obtaining a genetic test. So that's going to look at their DNA, and that's going to evaluate a panel of genes that include BRCA1, BRCA2, HOXB13, ATM. There's a whole panel of genes that we now test for. And that panel we always call multi-gene panel testing, meaning that there's more than one that we look at. We sequence the entire gene and we look for mutations. We have recognized that there are specific mutations in certain genes that increase your risk of prostate cancer. And we've done many analyses, and these have been performed in hundreds of thousands of populations. The study I'm showing here as an example looked at over 90,000, almost 90,000 patients. About 5,000 of those had prostate cancer. We compared them to those who didn't have prostate cancer. And 4 of those genes, a gene we call HOXB13, BRCA2, ATM, and CHEK2, all significantly increase your risk of prostate cancer. And again, without sharing all the details, not only did that significantly increase your risk 3 to 5-fold, et cetera, if you had one of those gene mutations, but if you generally had one of these mutations, you formed or were diagnosed at much earlier time points. So that's where, again, the recognition, if you have one of these mutations, we want to start screening you earlier, just so that we know that we're going to catch it at a time that's very treatable. HOXB13, I like to always point out, is a prostate cancer almost specific gene, meaning that men or who have mutations in HOXB13, really the disease that you're most likely to form is prostate cancer. There's not a lot of other cancers associated with it. I always bring it up because it generates a lot of excitement because there are not many genes that are specifically associated with prostate cancer. That is one of those genes. So if you hear about it, it certainly makes the news every once in a while. But the other ones, BRCA2, ATM, CHEK2, are also very, very important. But I'm saying these names really to help familiarize a lot of the listeners here on some of the genes that we deal with on a daily basis. I think it's obvious, and I think I went through this a little bit, but I think one of the most important tests that we can use in unaffected men is that polygenic or genetic risk score. And I think I've already stated the importance of that, because not only does that increase that risk, you can actually tell every patient at an early time point before you even start screening, what is your risk of being diagnosed with prostate cancer? Is that 6-fold higher than the population risk? Is it 80% lower? Is it somewhere in between? And based on that, you can have that shared decision-making discussion and talk about when the appropriate time would be to start your screening. Because the other part about that is that the higher your genetic risk score, the higher your polygenic risk score, the earlier the age of diagnosis. And certainly we know that if patients, and if you look on this side of the screen here, the left side, is that those patients who have a higher genetic risk score, certainly greater than a value of 1.5, are going to be diagnosed at much earlier time points than if you have a genetic risk score that is lower. So if you're lower than less than 0.5, indicating less than 50% of the risk compared to the general population, you tend to be older at the age of diagnosis. And when you look at that differential, there's over a 10-year difference in age between those in the highest 20%, meaning the who have high values, and those who have low values. So if you're going to personalize a screening strategy for patients, and you know that they're high risk, you want to start their screening earlier potentially more frequently, and that if you had a lower genetic risk score, you can actually wait or delay or de-intensify their screening practices. And again, as a comparison, if we use a current standard of family history, that really doesn't distinguish that difference. There's maybe a 2-year difference between those who had a positive family history and those who didn't. So yes, it is important to take into account, but it's not as dramatic in making that decision. So if we're going to identify a high-risk population that may benefit from earlier screening, it's going to be those who have the highest genetic load or the highest genetic risk score. Moving on along that journey is, can we use genetic testing to help us better understand the prognosis for patients who are newly diagnosed with localized prostate cancer? Again, we do know that about 40% or more of men are diagnosed with lower risk tumors these days. These mean men who have Gleason 6 or low volume Gleason 7 type tumors. We know that a lot of these patients are safe for programs like active surveillance that we can watch over time. But is every man who's undergoing or active surveillance or who has a seemingly more indolent type tumor, are they truly good candidates for active surveillance? Question mark. And two is that, can we utilize genetic testing to identify populations within those seemingly low risk men who actually are predisposed to more aggressive type tumors and are actually not good candidates for active surveillance? And so we have, again, done many studies in this space. And if we look at patients who have prostate cancer and we say, well, do any of the mutations in those rare pathogenic genes predisposed to metastatic cancer or lethal cancer, meaning those men who have tumors that have spread outside the prostate or who ultimately went on to succumb to the disease? Do any of those patients have mutations in any known rare pathogenic mutations? And it seems that at least 5, if not more, of those genes do increase your risk of really aggressive type tumors. Those include BRCA2, ATM, CHEK2, PALB2, and a gene called NBN. And because of that, if you have any of those mutations, you are more likely to have an aggressive type tumor, significantly anywhere between 5 to 10-fold. So again, it should set off some kind of red flag. But can we prospectively evaluate that? Can we look at that among men undergoing active surveillance? And so it's not surprising that when we've looked at our own active surveillance populations, and certainly Johns Hopkins and our collaborators there have also looked at this, and men with specific mutations, whether it's BRCA1, BRCA2, ATM, have all done poorly, if you will, in active surveillance, meaning that those patients who have these mutations, certainly in any of the 5 genes that we talked about, are significantly more likely to progress on active surveillance, meaning that over time, they're more likely to develop a higher Gleason 7 type tumor or an 8, 9, 10 type tumor, something that has a lot more potential. And while not shown here, we have reported that not only are they more likely to progress on active surveillance, but they typically will quickly go from a Gleason 6 to a Gleason 4+3, 8, 9, or 10 tumor. So that's about a 3.5 to 5-fold risk for a gene like ATM, meaning that men who harbor an ATM mutation have a significantly higher risk of progressing to a really unfavorable or high-risk tumor. So based on that, they may not be the best candidates for active surveillance, and caution should be raised if you identify those patients to putting them on active surveillance compared to an upfront treatment with either surgery or radiation. What is the role of polygenic risk scores in this space? And this is still a little bit of a moving target. Certainly, we do know that the higher your polygenic or genetic risk score, it is highly associated with the number of tumors that you have in your prostate. So again, prostate cancer doesn't just form as one area or one tumor in a man's prostate, but it forms as multiple tumors simultaneously. Certainly, that appears to be dictated by your genetic load, meaning that if you have a high polygenic risk score that measures your genetic load for prostate cancer, you're more likely to have, a number of tumors throughout your prostate. And therefore, based on that, we question, and there are active trials in this space currently, is if you're considering these days something like focal therapies, meaning that you're going to destroy just one area of your prostate with technologies such as irreversible electroporation or HIFU or cryoablation, you may not be the best candidate if you had a high genetic risk score, because even if you're destroying one area, you may be leaving multiple tumors behind. Does it have a role in active surveillance? Again, somewhat of a controversial topic because the results have been a little bit inconsistent, but it does appear that in some studies that your higher your genetic risk score is associated with a higher chance of failing active surveillance, meaning progressing or coming off of active surveillance. The concept isn't that far off or hard to understand, but the background there is that genetic risk score does not always predispose to more aggressive tumors. And there's a lot of controversy and mixed data there. But there is some suggestion that the higher your score, the more likely you are to fail. And this is a study by which we were a collaborator on, which was an international study that looked among men with active surveillance, looked at their genetic risk score, and then looked at their outcomes along active surveillance. And if you look at this left graph here, that genetic risk score for prostate cancer, the higher your genetic risk score, shown in yellow, the more likely you were to come off of active surveillance and require treatment with either surgery or radiation. I think the study needs to be validated, but again, for this purpose of this talk, it's just important for the listeners to be aware that these type of studies are currently underway and actively being investigated. I think the best known space for genetic testing, and this is somewhat driven by drug companies, is the use of genetic testing to evaluate therapeutic response, meaning that are there certain genetic mutations that predispose you to have a better or worse response to chemotherapies or radiation therapies or immunotherapies? And the answer is overwhelmingly yes. And so there are many trials now in the space. A lot of this is among men with advanced prostate cancer. Again, it's expounded and expanded outside of the prostate and lymph nodes or in bone. And these are either hormone sensitive or castrate resistant spaces. But there are certain gene mutations that include that BRCA family that do respond better to certain therapies. Those therapies include classes of medications such as what we call PARP inhibitors. So again, this is a type of oral drug that patients take that works specifically on those pathways that BRCA and their associated genes are known to be involved in. Those pathways are called a DNA damage response or DDR response pathways. And again, if there's a silver lining to having a mutation in one of those such genes, it is that it imparts for select patients an improved response to certain therapies. And this has now been evaluated for PARP inhibitors. It's been evaluated for platinum-based therapy, and certain genes known as mismatch repair genes also seem to respond really well if you have a mutation in those genes to immunotherapies. So again, this space continues to expand. But this is in the era of personalized medicine, saying that if we evaluate patients for these type of responses in your germline DNA, you are likely to have a nice response to your hormone or chemotherapy. And while I'm talking about germline DNA, remember there's a whole nother side to this, which is tumor or somatic DNA. And certainly many of these same gene mutations, which we're talking about here, are also very relevant in the somatic DNA testing space. And so if you have one of those mutations there, you're also likely to respond well to these type of therapies. So it is something that is actively being evaluated in the clinic all the time now as part of almost routine care in the setting to better match up with chemo and hormone therapies to improve patient outcomes. There's not a lot in the polygenic risk score in this setting, meaning that polygenic risk score does not associate with specific chemotherapies at this time and to our understanding. However, there are certain SNPs or variations throughout the DNA that do appear to predict some response. And there is a variation in a gene called HSD3B1 that has reproducibly been validated to associate with the time of response to hormone therapy, meaning that prostate tumors respond well when you starve them of their testosterone. And so many therapies that we call androgen deprivation therapies work by getting rid of testosterone. And certainly there are variations throughout the DNA, this one called HSD3B1, that are associated with a decreased response time to those hormone therapies. And as you can see here, if you have 2 copies of that variation shown in red, you're less likely to respond for a sustained duration. So it is one of those where we're taking note of that now, because many of these patients, instead of just upfront and solely maintained hormone therapy, once they start failing, we should have an earlier threshold to institute a different type of chemotherapy. Again, this has been validated in many, many studies, and its routine implementation in clinic is certainly becoming more increasingly observed. So in summary right now, germline testing is really important. It's important for clinicians and patients to make better and personalized decisions along the prostate cancer journey. It's important for unaffected men because it can really identify who's at risk or actually at lower risk. And based on that, it can help, really personalize your prostate cancer testing or screening. So again, higher risk men, we're going to screen earlier and potentially more frequently. Lower risk men, we can potentially de-intensify the timing and the frequency of screening. Genetic assessment is used for newly diagnosed men and certainly can help provide caution for those men who are undergoing active surveillance or focal therapy if you have certain mutations. It can help identify the right chemotherapy and the timing of that chemotherapy for men with metastatic disease. And finally, although we didn't talk about it as much, is that it helps that patient as well as family members improve their screening practices for cancers that they may also be at risk for, whether that's breast, ovarian, pancreatic, melanoma, et cetera. And so knowledge is power, and early genetic testing, really at upfront and an early time point in a patient's life, really can help us make improved decisions. So I believe it should be used along that journey for every single individual. So what's new? Did I spill all the beans already? There's a lot of excitement, and I do believe that we only have really touched the tip of the iceberg, and the best is still yet to come. And I think just to show you on some latest projects that we and others have been working on is how can we apply genetic testing to look at other aspects of prostate cancer. And so one of the projects that I think is most exciting and has a potential for a large impact here is that, as I said, is that there are men with advanced prostate cancer. A standard of care treatment, it usually involves androgen deprivation therapy or ADT. And these include classes of medications that get rid of your testosterone or block the synthesis of testosterone or hormones or block the testosterone from acting on receptors in the cell. And there's a lot of these type of medications, certainly historic ADT. Usually most people think about Leuprolide or Degarolex, etc. Those are the ones that are most commonly used. And although they're really good for treating and containing prostate cancer, certainly we've realized over the years that there is nothing benign. And even though they're good and again, they don't cure, but they control prostate cancer, there are certainly side effects and long-term side effects that we're become aware of. And certainly it's becoming increasingly important, not only for clinicians and patients to recognize that you are at increased risk, even with one dose of things like depression. You are at increased risk of osteoporosis, meaning your bones become frail and you can fall and break your bones. You are at increased risk of cardiovascular disease if you have exposure to hormone or therapy or androgen deprivation therapy. So knowledge of that is important. And the question is, can we use genetic testing specifically to identify those patients who are most at risk of developing these side effects? And the answer is yes. So can polygenic risk scores, that what I talked about, be used to predict adverse events from androgen deprivation therapy? And again, these are not polygenic risk scores that are specific for prostate cancer. So these are different than the one I just spoke about, but these are polygenic risk scores that are specific for osteoporosis, that are specific for depression, that are specific for cardiovascular disease. And so I just want to give you a little bit of insight into some of the projects that we've looked at, both in large data sets, but we've also now validated in our own institutional data sets. And that is to say that if you're going to undergo androgen deprivation therapy, what are your risks here? So we used a data set called the UK Biobank. So this is a prospective data set that involves over 250,000 men that have been followed for over 15 years out of the United Kingdom. And some of those men were diagnosed with prostate cancer, and some of those men were diagnosed and ultimately developed metastatic prostate cancer that went on to kill them. And so what we can use that database is to say, well, if you had a metastatic prostate cancer and you were exposed to androgen deprivation therapy, do you have increased risk of cardiovascular disease or osteoporosis or depression? And certainly when we look at all prostate cancer cases, the answer is yes. If you have risk of all of that, even if you just were diagnosed with prostate cancer. But that risk is really exaggerated among men with metastatic cancer who were exposed to ADT. Because as an example here, if you didn't have that androgen exposure and you just had localized cancer and treated, you have basically average population risk of heart disease. You have about 2-fold higher risk of osteoporosis and about 1.4 higher risk of depression. But if you had metastatic disease, you have about 1.5-fold higher risk of heart disease, about 5-fold higher risk of osteoporosis, and over a 2.5-fold higher risk of developing depression. So, okay, so that's there. Are there tools even among those cohorts to help us better risk stratify that? And again, the answer is yes. So if we compare those men in that same data set with metastatic to non-metastatic disease, metastatic patients who had advanced prostate cancer because presumably of that the hormone exposure, that they have almost a 1.4 fold higher risk of being diagnosed with cardiovascular disease. If you specifically look at men who have a low, an average or a high polygenic risk score for cardiovascular disease, you can then stratify that patient population with metastatic prostate cancer. Meaning if we look at patients in the red line here, those are patients who have the highest polygenic risk score for cardiovascular disease. It turns out they are tenfold higher at risk of developing a heart event, like a heart attack, throughout their follow-up period. And certainly, if you're at low risk, you're only about 1.3-fold higher risk. So again, you can stratify patients. And again, so if you imagine that you see a patient in clinic who has advanced prostate cancer, and they're so worried about their prostate cancer, and you're there as their treating physician, and you're really focused also on their prostate cancer, but you get a polygenic risk score for heart disease, and it says they're tenfold higher risk of heart attack, you're going to make sure that they're seeing their primary care physician, their cardiologist, to ensure that we can do things to maximize their heart health and hopefully prevent those cardiac events. That's really how we are envisioning using a germline genetic risk assessment for heart disease to better risk stratify patients undergoing hormone therapy. The same results were seen for osteoporosis, and then I'll show you depression, is that if you compare men with metastatic prostate cancer versus non-metastatic prostate cancer, there's over a 2.6-fold higher risk of osteoporosis among men presumably undergoing hormone therapy. And again, that risk can be stratified by your genetic risk score. So if you have a genetic risk score that is in the high category, in the top 10%, you're going to see that those patients have over a 16-fold higher risk than the average patient in the population of being diagnosed and treated for osteoporosis versus those who are in the lower risk. Again, it's a risk stratification tool that really allows us to identify those patients who are more likely to develop that phenotype of osteoporosis, be proactive with them, put them on the appropriate medications to prevent that osteoporosis and the bone degrading side effects of that hormone therapy. And certainly depression is really becoming a focused topic among patients with prostate cancer in general, but also specifically with metastatic prostate cancer. It's important for myself as a treating provider to recognize it, to screen for it, because again, so many patients have increased risk of depression. Specifically, if you have metastatic prostate cancer, that's twofold higher than patients with non-metastatic prostate cancer, and actually almost fourfold higher than patients without any cancer at all. So it is one of those where we really have to pay attention to it because, again, that is a treatable thing that certainly affects quality and potentially longevity of life. And when you look and you use that same type of risk stratification, there is a separate genetic risk score for depression. And again, you can identify those patients who are fivefold or fourfold higher risk based on that. So it is, again, something that not only is forced to call our attention to those high risk patients, but if you are going to put a patient on an androgen deprivation therapy, I do believe that it is important to get that genetic testing, not only because it makes you, it forces you to look and identify those high-risk patients, but again, it's to hopefully be proactive and force you to be proactive in treating those conditions before they even develop. And so I'm going to end this by saying that certainly a lot of this is here and now. And while we always have ongoing studies, a lot of this is actually commercially available. As a just full disclosure, I do not get any money from this testing at all. I do believe in testing, and certainly we have partnered with GoPath Diagnostics to help develop prostate cancer specific tests that do incorporate a lot of this type of rare pathogenic, the polygenic risk scores for prostate cancer, for the osteoporosis, for all those associated diseases. If you are interested, whether in a study or certainly in obtaining genetic testing, you can use this QR code or the site that will kind of help direct you to therapies to obtain that. There are, as part of that, genetic counselors who can go through this with you. But it is, again, if it's a clinical test and you choose to get it clinically, there can be an associated fee with it. Again, most of that is associated or is covered by insurance. These days, as I told you, genetic testing has decreased in price substantially, and most of that type of testing, if you were going to pay out of pocket, is generally between 200 to 250 US dollars. So again, it is available if you are interested to participate or obtain your genetic risk. And so with that, I certainly thank you for your time, your efforts, and your attention. And hopefully you find this valuable. And I have made you a believer that germline genetic testing is an important tool that should be implemented as routine practice along that prostate cancer journey. So thank you guys very much.
And there it is, the great Dr. Helfand giving a Helfand of a talk. How do you like that?
That is something. I haven't heard that since grade school, I think, maybe.
Really? You went to grade school with some very smart people. It was an excellent talk. So people understand. I've seen Dr. Helfand talk many times. Here comes the quick ego boost. There are very few people we want globally to give this talk more than him. This is what he does. He's out there. He does the meetings. He publishes. He works with a lot of advocacy groups. But so when we thought we need someone just to explain some genetics, we immediately thought of him. And unfortunately, he gave me his cell phone. And I called in on a whim and we tried to add the subject at the 9th hour, and he graciously agreed. But, I don't want to go through your CV too much because that's already on the website. But when it says North Shore University Health System in Evanston, I thought of something interesting. So if it's North Shore Urology, is that in Hawaii, right? Are you a bunch of surfing urologists? So tell us about North Shore and what it's affiliated with, because even though it's in the booklet and I know, I'm not so sure the audience knows. Is it in Hawaii?
I wish it was in Hawaii. Our weather is not quite that good, although with global warming, it's getting better and better. We are on the North Shore of Chicago. We actually sit on Northwestern University's undergraduate campus. It actually is the oldest hospital in the Chicagoland area.
Wow.
We've had a lot of kind of weird breakthroughs through the years that have been at least initiated here in terms of a lot of like pertussis vaccine. And I think that was the kind of start of fame. And although it was years ahead of my time, a lot of even the initial genetic studies started here as well. We were actually the original Northwestern Hospital. We used to be part and associated with Northwestern, and then now about 13, 14 years ago, we separated ways and are part of University of Chicago. So that's the politics of Chicago, that everyone's kind of mixed and hybrid. And the nice thing is we're all friends, and we just call each other different names based on the time of year and day and who we're associated with.
Yeah, but you're the endowed chair of urology there, correct?
Correct.
But really, you also are the director of this clinical research in the program for personalized cancer care. So you wear that hat too. You wear a lot of hats besides being, your bio is interesting because when I read it, it says internationally known. And between me and you, and a lot of doctors say internationally known, no one's heard of them. But you're different, right? You do all the meetings. You do all the publications. So this is a real treat for everyone. What I didn't know about you, and I thought we would share this a lot, is, I was probably this close away from getting a PhD in pathology. And I went, that's okay. I don't want to do it. You ended up doing two things I would want to do if I could come back in another life, but I couldn't do it because I was too wimpy. The first one is you finished a PhD in cell and molecular biology and genetics from Northwestern. Dear Lord, that's got nerd written all over it. That's beautiful. I love that. And so you really, this was what you studied going before you went into practice and all that, right?
It was actually, everything was very fortuitous. And I initially ended up, if you want to really unveil the curtains here, I did a lot of research when I was an undergraduate at Emory University. And a lot of that was because I was trying to help pay for college. And then the opportunity to use that and join a medical scientist training program where they paid actually for medical school became very attractive to me. So unlike a lot of my colleagues, I don't have that debt or never had that debt. And so I then use that as an opportunity to really get involved in research. And one of the cool parts of a lab I joined was that I had the opportunity to go out to Woods Hole, Massachusetts every year and study things like squid axons and genetics and all that kind of stuff there. So it allowed me to travel and do really cool things. But really, I was getting, as you said, kind of nerded out by all of the stuff that was really just kind of coming of being. So a lot of that genetic technologies and stuff were really just starting. And as I ultimately then started my endeavor in urology, I was introduced to Bill Catalona, so considered one of the grandfathers, if you will, of prostate surgery. And he looked at me and said, "Oh, you do genetics. Do I have projects for you?" So that's really, and I thank him and just a lot of good opportunity that he got me involved very early on with a lot of these groups.
That's awesome. The other thing you did that I wasn't able to accomplish is I applied to Emory University for college and I was waitlisted. And when I did the interview there, it was the most classic bumbling of an interview I've ever had in my life. The person interviewing me, who was in the administration, this is a true story, said, "Well, why do you want to come here?" And I said, "Well, partly I want to play college basketball because I played in high school and I was pretty good." And I didn't realize at the time when I'm doing the interview that they didn't have a college basketball team. So she informed me that they didn't during the interview, and I thought, "Oh, geez, I don't know if I'm going to get in here now."
You could have been the original, the OG.
I could have been the Shaquille O'Neal of Emory University, or the Kobe, or I don't know. I could have been somebody. All right, and you didn't see this. The last part of your bio says his best friend in 2024 is Mark Moyad. I threw that in there, by the way. I thought you might.
That is true.
All right. Thank you. I got a couple genetics jokes, and then we're really going to hit it hard and see if I can put my head around this really tough topic, okay? All right, so I thought I'd come up with some genetics jokes and see how you would rate them on a scale of 1 to 10, 10 being the best ever, 1, it sucks, get away from me. Why did one DNA strand get mad at the other one? Because he claimed he was being copied.
Oh, that's a good one, actually.
Thank you. What did one DNA strand say to the other? "You complete me." What did one DNA strand say to the others? "Do these genes make me look fat?" What does Dr. Helfand
say that you used to write for Hallmark?
I don't. It doesn't matter.
I like these.
It doesn't matter. All it takes is one laugh, and I'm encouraged. What does Dr. Helfand and his team look? Why? Sorry. See, you could tell I just worked on these. Why does Dr. Helfand and his team look forward to casual Fridays? Because they're allowed to wear jeans at work.
Oh, jeez.
Or to work. Sorry. These are the best I can come up with. And then what do you call a genetically engineered cow? A mutant. I'll be here all week. Don't forget to tip your wait staff. All right. Last important point, most important point, to get to know Dr. Helfand before we get into the weeds. He wanted to go to Michigan. Remember that. He told me it secretly, so now it's out in the public. Yay or nay, Dr. Helfand, you actually wanted to go to the University of Michigan, the national football champions of 2023-24.
You know what? I have a very soft part in my heart for Michigan. I always will. There we go. That's what I was hoping for one day. So much of my family has gone to Michigan, but when it came down to deciding, somehow my parents said that I would have to go to our local state school, which is just, and kudos to University of Illinois. I love them, but it they dissuaded me because of financial reasons more than anything else from Michigan. But Emory was great as well. But yes, I have a very strong fondness for Michigan.
Okay, we got through 6-7 minutes without any talking about, not even talking about genetics. So now we're going to buckle up. I got my green tea with L-theanine, which is sort of a relaxant, it's a stress-free hormone. Actually, it's an amino acid. And now we're going to talk about genetics. Ugh, is what I say. All right. Are you ready for my first question?
I'm ready. Bracing myself after those jokes.
I don't joke. I know you'd give them 10 if you had a chance to give them 10.
For sure.
Let's go through the basics again of your talk. See, this is where people get confused, including healthcare professionals. There's two types of genetic testing. Germline, which is what we focused on today, and then people get it confused with somatic. And can you walk us through that again? Because you said this in a talk that I went to. You go, look, germline are the genes you were born with. You had them on the day that you were a baby when you had those, and you have them the rest of your life. Somatic is what your tumor itself is showing. So somatic is reflection of the tumor, and germline is what you were born with, and you're going to continue to have your entire life from birth to death. Do you want to expand on that, or am I get that right?
I think it becomes confusing because every cell in your body starts off with normal germline DNA. That's what we're born with. That's what we pass along. That's what we inherited. That is you from the time you're born to the time you die. A tumor only changes. It takes your germline DNA, and there are changes that happen to that because of it's a tumor, and it accumulates that damage in the DNA, and that is just locally grows, but that's not passed on. So that's the biggest difference, is you cannot pass on your tumor DNA.
Ha. This is why we got a bunch of questions and people get confused. So germline is what you're stuck with the rest of your life, like it or not, and you could pass that on. Somatic is what the tumor is showing. You don't pass that on. I mean, theoretically, sometimes things could pop up, but you don't pass it on, right? So here's what I'm going to jump ahead and then come back, and you're going to see this is all over the place. But I took some of the questions that I get from doctors, healthcare professionals, and what we got at PCRI. Okay, so let's just play this game for a second. I'm going to jump ahead. Someone goes out and has advanced disease, okay? They have a BRCA2 mutations found on a somatic test. So you talked about germline. Does the family need to be tested? Brian, I can't tell you how many calls that we've received that actually this question came in. In other words, somebody with advanced prostate cancer came up positive on a somatic BRCA2. And then the family member is like, oh my God, I got to get with a genetic counselor. I got to get tested. My germline has to be tested. Do you want to comment on that?
I do, actually, because it's a sensitive subject for two reasons. Number one, just to rephrase the question to make sure everyone understands it, is I have a prostate tumor, and we biopsied that tumor, and we found that there was a BRCA2 mutation in that tumor.
Yes.
And the reason why that's sensitive from a testing standpoint is that not every single company tests the germline automatically. So meaning that if you think about BRCA2 mutations in a tumor, that can happen one of two ways. That can happen because a patient who is born with the BRCA2 mutation, and it's in every single one of his cells, forms a tumor because we know that they're more likely, and then that exacerbates it, so we detect it in that tumor. Or it could be a spontaneous, if you will, type of mutation, meaning, as I used, because I think it's easy to understand, is the patient is outside in the sun hits an area of the skin, that area of the skin forms a melanoma, and that melanoma has a new mutation in BRCA, or a mutation in BRCA2 that's not in every single cell, so it's only in that melanoma tumor. So it's important that if you find a somatic mutation, that patient is also tested in their blood, their germline, right? So take a tissue type that it doesn't have cancer, test that, make sure that it's not a germline mutation. If it is a germline mutation, then the answer is yes, not only does that have implications for that patient, but it also has implications potentially for their family members if they also have that type of mutation. But if it's only just in the tumor, then it doesn't. So the reason why I think it's sensitive is a lot of companies don't offer that germline reflexive testing. And why the harm of that is really, again, we obviously care and focus in on the patient, and the patient is fine in getting treatment just based on understanding that somatic. But I think it's important to understand the whole patient, including their family.
Yeah.
So we don't want to miss that opportunity, because if those patients, family members are at increased risk, it will certainly help screen them so they don't end up in a similar type of spot.
So just because I have a BRCA2 on my tissue or my somatic test, it doesn't mean I'm going to have it in my germline. And the only way it means that is what you're saying, if you test germline, which now brings up the next incredible question that I want you to answer. Because again, I just want we talk about advanced disease right now for a second before we go back to the rest of your talk. I just want to get these out of the way. These are important. So now let's say you find a BRCA2 on your somatic test, right? Should you then just go ahead and do a germline anyway? In other words, think about the ramifications of this question. And this is why I just get so excited about this geeky stuff that you get excited about. Everybody's running around in advanced disease, right? And this is going to apply earlier. They're getting a somatic test. They're being tested on their tumor for BRCA, Hawks. It doesn't matter, any of these mutations. Should they just keep sticking with the somatic, or should everybody also get a germline test who has advanced disease? In other words, should they always request both? Because the doctor is more than likely going to request the somatic. Wouldn't you agree? Probably. What do we do with the germline test on an advanced person?
This is really what motivates the drug industry, right? Is because if you have a somatic test, it's going to somatic mutation, I should say, and it comes up BRCA2. And number one, it can change throughout time. It can vary. You may not have one. You may form one. Depends on, as that tumor progresses, depends on what we expose that tumor to, hormone therapy, chemotherapy. Your mutational landscape will actually change over time. So it's not inappropriate to test somatically the tumor, whether it's in the tumor itself or in circulating tumor cells throughout the blood, et cetera, periodically as that disease state changes. But at some point, because all of those patients qualify, and certainly I say qualify because it's covered by insurance, that they should be tested for their germline tumor, again, because it has implications, certainly for the patient, but also their family members. Again, it's that holistic care of the patient that we're really concerned about.
Let me repeat that for the audience. Anyone who's being tested with a somatic test, generally speaking, you are a fan of, at least at some point, since it's a one and done test for the most part, they should also get a germline test. That's what you're saying?
That's what I'm saying.
Thank you. All right, that makes me happy. I'm not just saying my opinion wise, that makes me happy, because a lot of people have to understand the difference, and you can get multiple somatic tests over time, but just getting that one germline, why not just get it? And I think that comes down to advocacy. I think a lot of people don't get a germline test because they aren't able to advocate for themselves. It's not offered. I don't know. Am I causing controversy? Are you?
No, I think it's a moving target. And I think, unfortunately, again, a lot of this has been based upon insurance rules, right? Only certain populations considered high risk based on family history. And I already think I said is that there are limitations to that. And actually, just to add in, 60% of patients who don't meet criteria will actually harbor a mutation. So it is.
Can you repeat that statistic? Because this is what I learned too this past week. I don't know if we're talking about like the impact study or some study out there, but will you repeat what you just said? Because this is mind-blowing. 60% of patients
who don't meet insurance criteria based on family history will actually harbor a mutation.
What the hell, fan?
That's
I
what
mean,
I love
come
it. I love it.
on.
It's a verb now too. I love it.
I know, right? I mean, this is okay. This is really good. I'm sorry. Were you going to say more about that? Because I'm so tired of people not mentioning that. They make it sound like if you have family history, oh, if we can figure it out, then we can, you know, I can't tell you how many times they'll say, well, there's not a family history there. So then why do the test? Because 60%. In other words, it's an imperfect system. That's why you ask for the test.
Right. And again, it's when you compare the cost of genetic testing these days to so many other costs out there, it's peanuts. It's peanuts to what we're spending in healthcare. And again, if you get these tests, and because they're multi-gene panel, et cetera, you can get them early on. And hopefully, I've convinced some people out there that that information can be used upfront before you even have any type of tumor to really help guide your screening in a more precise fashion. Again, it's just a quantified, like a test that we can use to really assess your risk of disease.
Insurance not going to cover it. People don't want to cover it. Let's just say, how much are they going to charge me if I just want a germline test? Do you think, ballpark?
In the US, almost every single genetic testing company that I know of, again, these are DNA-based tests, are offered. Most of them have a deal, and I think they've competed with themselves that it's $249 or less. That's almost uniform across the board if you paid out of pocket. Now, again, for those patients who meet criteria for genetic testing, that's almost always covered.
$249. Look, I understand the expenses, but some people go out to dinner and spend $249. So I don't work with any of these companies, but I'm just telling you, we're going to get back to this controversy, which shouldn't be a controversy. Okay, now I can breathe a little bit more. I just want to focus in on something you talked about a lot. Then I want to leave it again and then go back to the sort of some of these main mutations that people are familiar with. You talked about genetic risk score and polygenic risk score, right? But so here's what I'm thinking of, because these are germline. When would I know to even get these? Because when people think of genetics, they think of BRCA2, they think of ATM, they think of BRCA1. They don't think of genetic risk scores and polygenic risk scores. Are these ready for prime time yet? And are they ready for prime time? I'd like to know a little about the costs. And then I'm going to tell you what your critics are going to say against you after you tell me about who gets it, who's watching. Do I actually ask for this? Any guide there?
Right. So even though they're well studied, okay, and just as a comparison, before we go into any details here, is that when we talk about rare pathogenic mutations, and those are in, again, genes like BRCA1, BRCA2, they're rare, right? And so when we look at the incidence of these mutations in the overall population, if you look at a whole group of them, less than 3% of the population will have any of these. That's a whole panel, right? So if you look at an individual BRCA2, it's about 0.2%, right? So it's a very low risk of having these mutations. And even though they're so low risk, that makes them really hard to study, right? So it's taken us years to accumulate enough patients with these mutations to ultimately get a story out of them. And even then, we group all BRCA2 mutations together, right? Because you can have a whole gene and you can have a mutation in one spot and someone with a mutation in another. And we say, everyone has a mutation, but we really don't know if they're really the same. But they're so rare, it's hard to make that conclusion. And so, but somehow, and a lot of this is because of the influence of pharmaceuticals and the money there, we just accept this as fact, and everyone should be tested for these because of the clinical implications, which I'm not opposed to. But then we take something like polygenic risk score, which has not only been studied for a long time, but has been validated in countless numbers of populations, in countless number of patients with diseases, without diseases, but we're a little bit more reticent to bring it in. And that's because it really doesn't follow what we call Mendelian genetics. So Mendelian inheritance, when you have two copies of a gene, 50% of the time you get one gene, it goes to, one offspring, 50% goes out. That's what we're used to doing. And that's what genetic counselors and genetic medicine physicians are really used to talking about and counseling about, et cetera. Polygenic risk scores kind of take that and explode, right? It says, hey, the average person like myself who doesn't really know that much, I can use that because I know in medicine how to use odds ratios. I know it says, hey, this is high risk and low risk. And that's how we're really used to making decisions. It hasn't been implemented because it hasn't necessarily received that support from a lot of the groups because it's controlled a lot by medical genetics. They're starting to understand, and certainly the more progressive ones are the importance of them, because there's a whole another side to this, is that, as I said, is that certain genes like BRCA2 increase your risk of pancreatic cancer, increase your risk of melanoma, prostate cancer, yada, yada. And so if you have a high polygenic risk score for breast cancer and a low one for prostate cancer, you're more likely to develop, if you have a BRCA2, breast cancer than prostate in that. So it actually can modify the BRCA2 effect. So there's so many uses of it that I think we're just starting to see the implementation of the polygenic risk scores.
Well, then are you recommending people that are watching this dealing with prostate cancer, they don't go in and ask about a polygenic risk score to add to their prognosis? They just kind of are waiting to see how this is going to play out. This is just what's coming next. How would you have the audience look at this?
So I'm biased. I'm totally biased because I do this type of testing all the time. And, to be frank, in the setting of screening, in the setting of newly diagnosed patients, while I get so excited, which sounds really, talk about nerd, so excited when I see a patient with a rare pathogenic mutation, it's the polygenic risk score that affects my practice and affects patient behaviors, if you will, more frequently than the rare pathogenic mutations, because it just there's a lot of higher risk patients we identify.
These are the patients coming in for screening. They haven't been diagnosed yet. Or are you saying you're using this PRS polygenic risk score even right after they're diagnosed to give you some more information?
Just information about why they may have formed it, and even more in unaffected men who, kind of present to the clinic and are asking, saying, hey, should I get a biopsy? Should I not? We do know, again, that the polygenic risk score, it stratifies your PSA value. So if you have an elevated PSA and an elevated genetic risk score, the patient with an elevated genetic risk score is going to be more likely to harbor prostate cancer on a biopsy than those without it. So it is one of those where it helps stratify my decision making.
It does, but it sounds like it really helps you right now in terms of deciding whether or not to biopsy, whether or not you think someone might have cancer, but it's not so much used right now after the diagnosis or someone with advanced disease. Is that fair?
That is fair. It's really that upfront. And then as we talked about, the rare pathogenic mutations become more and more important as the journey progresses.
Yeah. Well, can I tell you what people say about you behind your back?
Totally. Okay. There's a lot of...
Not you specifically. It's what the literature says about these polygenic risk scores, because they're exciting, because you've taught me about these SNPs, these single nucleotide polymorphisms. So even though I called it a mutation, it's a tiny type of DNA variant. I think I like the word you said. And ultimately it's a fingerprint, right? It's something that's going to give you more information in the future. And that's exciting. What the critics are saying about using all these risk scores right now is they're saying, look, it's not showing us whether or not someone could possibly die from prostate cancer, is going to get aggressive disease or have lethal prostate cancer. So it's just telling us who might get prostate cancer, which is just a lot of people. It's not telling us the significant prostate tumors or whose life might be threatened. So it's not really being that helpful. That's what your critics say. And what do you say?
Again, I think the holy grail in prostate cancer and prostate cancer screening is identify those patients who are most at risk of dying from prostate cancer. That's where
Right.
we're going to get it. Unfortunately, I personally believe that holy grail doesn't exist. And the reason why, and again, I'm just a skeptic, is that the tumor changes throughout time, right? Or you can have a new tumor develop that is more aggressive. It's a multifocal cancer. Each cancer has its own ability to have its own aggressive potential or not potential. And certainly where we pick patients up in the screening process really confounds our interpretation, right? Because we thought at one point that if you had a family history of prostate cancer, that predisposed to aggressive disease. And it turned out that actually, if you have that family history, you're more likely to have a lower risk type tumor because we're over screening you. So screening influences that kind of path. So I think really the purpose is to really narrow down our screening pool. Meaning if you don't have no information on patients and you say, well, or even just family history, you're going to say, well, if we take the whole circle, we'll be able to take about 7% of that population, focus our screening there. Even though others are at risk, is that really informative? Probably not. But if we add polygenic risk score, that's going to focus our spotlight, our flashlight on a patient population that's most likely to get prostate cancer. And we can focus and identify our winners early on so that they don't develop those metastatic tumors.
Are you using polygenic risk score right now for your active surveillance patients?
They do all get it.
They do all get it. Okay.
That's the research protocol. So those patients all don't know we do, but they don't know it. We don't know it from behind the scenes, but it has some utility there. And again, we have certain trials in focal therapy saying, hey, are you a really good candidate? If you have a high polygenic risk score, are you likely to have a recurrence in field pretty quickly?
Okay, let's talk about let's talk about things around diagnosis and early stage disease and just cover this is going to be just all over the place. You more than anybody made me feel good about me because I have argued at some of these meetings, but I think you argue it more eloquently and you argue it with more data, that what does family history really mean? I think somebody could give an entire lecture on the fact that in prostate cancer, you can chuck a lot of family history out the window that we're not really sure what we're doing or people know what they're doing. So before you answer the question, the reason why I thought family history was so strange is that every time you talk to a practitioner or a patient, their definition was varied. There was no standard definition. Was it the number of prostate cancers in your family? A lot of people think that's it. Or how about, is it the number just of aggressive prostate cancers or the ones that had prostate cancer early at an earlier age? Some people believe it has nothing to do with any of that. It's just the total. Like in my family, we got a ton of cancer of every type. Does that mean I have a strong family history? Every one of these scenarios and more, to me, in my career, has been defined as a significant family history. And that means to me, we don't really know what we're doing when it comes to family history. What is a family history to you?
And it's changed because I think, like most urologists, I think we're from the start, when we talk about prostate cancer and we talk about seeing a patient in clinic, we always say, well, do you have a family history of prostate cancer? Yes, no, I don't know. I don't talk to my family about that. My father had some procedure on his prostate. I don't know what that was. So that's what we were based on. And the truth is, it's not that it wasn't somewhat informative. It just was only a small sliver of the pie. And so ultimately, what excites me more these days, and it's because of the association with finding a rare pathogenic mutation, is it's not just prostate cancer. It's those families that actually almost sometimes have very little prostate cancers, but they have other cancers, glioblastoma, pancreatic, breast cancer, and all of that stuff, lymphomas. Those are all more likely to harbor those mutations. So I get more excited when I see an extended family history. Now, when I talk to a lot of clinicians, they say, Brian, That's great. What are you making a pedigree in your office? I mean, are you calculating this? No, I don't. We do have programs built into our system that if we want to do that family history pedigree, we can. I'm not a genetic counselor. I do nerd out by looking at a lot of that. But on the other hand I think just having a list of 5 or 6 cancers, I always run through and say, well, do you have a family history of cancer? That includes, do you have a family history of breast, ovarian, colorectal, pancreatic, endometrial, melanoma? That takes me literally a nanosecond to reel off, but it at least spurs that patient on to start recalling and saying, well, yeah, that person had this. So you're recording that. Now, I also record age of diagnosis of those cancers. Yeah, my sister had breast cancer. It was age 45. Did she die from it? She went on, unfortunately, to die from it. So that I also record. Again, that whole type of history doesn't take very long to do, but it is very informative of who's more likely to it, to have that. On the other hand, is what I think is that this blows it all out of the water and saying, you know what, I don't have time to do it. I don't want to. Just get that test. It'll be a lot more informative up front, because it serves as a quantified family history. And that's really a polygenic risk score. It's a quantified number that tells me what is your risk of prostate cancer that I care about.
To me, you're saying that all of this, maybe why people haven't done a great job is because all of this actually makes a difference. The number of prostate cancers, the age at which they were diagnosed, whether or not they were aggressive, what age, like I mentioned, age, total number of it seems what you said in your answer is that because all of this matters, so why don't we just get a test?
Correct. Right. And you're barely, all those words barely fit on a page, right? There's a lot of things that matters there. So when you talk about time constraints in clinic and you want to get that information, a lot of practitioners get nervous of saying like, hey, I just don't have time for all of that stuff. So this is what can easily replace it, and I think is a lot more accurate.
Yeah, I wish the questionnaire said that. Number of total cancers, age at which diagnosed, did anyone die of those cancers? What about these other specific? Oh man, that would be a great one-pager. And that's why, you made me think about that. Maybe that's why family histories become so difficult. So again, can you remind me that even if you do a family history, the vast majority of men who come up BRCA, for example, positive, don't necessarily fit in that family history is what I think you said.
60%. So that's where there's been a call to our guideline committees to say, maybe we need to be more inclusive. Maybe we shouldn't be so restrictive as these insurance companies continue to try to hunker down and limit it. We said, this is not a place that you should be limiting.
Okay. So then that takes me to active surveillance. All right. I want to set this up, just give you some context. When we were doing the big national meeting, and we're doing it again in the fall, it was probably 3 or 4 years ago, we would say, well, why doesn't everybody with advanced disease, maybe longer, maybe 5, 6, why doesn't everyone with advanced disease just get genetic testing, somatic, germline, what we talked about? And then it came, right? Now that's a part of guidelines. Okay. Everything you said, everything I said brings up this question, and I'm still shocked by some answers. Active surveillance. Why? No, and this is an honest question. Why isn't every man tested for BRCA or just get some type of germline test? I put family history as a wimpy guide. I didn't mean to do that. Anyway, I forgot I put that in there. Anyway, but this is the $1 million question of part of your lecture. Active surveillance. Why isn't every man tested for BRCA? Because my understanding is, and you can give us some background to all this, in preliminary research, men who are BRCA positive and have some other types of mutations are much more likely to come off of it because they have a more aggressive type of disease. Their disease is more likely to progress. And these are people that might not be good active surveillance patients. So again, my question is, can you give us some background? Why isn't it standard of care today that everyone on active surveillance, if you want to be on it and stay on it, you've got to be genetically tested?
It's a variable that you can definitely factor in. This comes a little bit to yield, right? Is that and I'm playing a little bit double sides of the coin here, is that, on one hand, I believe everyone should just have genetic testing up front and we'd have that answer going in, so it really wouldn't be an issue. But under the current guidelines and when you look at everything is that the frequency of genetic mutations increases in proportion to Gleason score and stage. Okay. So you're going to have ultimately higher numbers of patients who have mutations with higher Gleason scores than lower. That doesn't, it's not foolproof by any means. And you can certainly see patients at lower risk. So right now we're still restricted based on family history guidelines in terms of that. But I do think that if you identify those patients, and again, they're rare. So in the active surveillance, which is it's a little bit more similar to the general population, really less than 2 to 3% of those patients will harbor those mutations, that they say, hey, that's not a high yield patient population to look at. Although we do know that if you are one of those patients who has those mutations, the chance of you progressing, failing active surveillance is a lot higher. And again, it's not one of those where you go from like a low risk grade group 1 to grade group 2. You generally go from a grade group 1 to a 3, 4, or 5.
Okay. So what you're saying is, it is true right now. It's not called for yet in guidelines to test active surveillance patients with a germline test to see what's going on. But in studies thus far, it has been a predictor of who might not want to stay on active surveillance, potentially. It's not solid data. So again, I go back to the question, do you test all of your active surveillance patients with germline testing, or are you waiting to get more data?
I offer it to every single patient.
You offer it to everyone.
I offer it to every patient with an explanation of, if it's not covered, you may be responsible for a $249 bill. Again, that doesn't have to be decided at the visit. They can talk about it with the company, the genetic counselor, et cetera. But that's that's why I explain the utility of it. Is it may explain why you have prostate cancer. It may influence how we treat you.
Okay, so at least you offer it to everybody on active surveillance. I have one place in your entire talk that I'm totally biased. I don't understand it. We have a genetic test. It's a germline test. It's $250. We have all this criteria of what it takes to be on active surveillance. Patients go through a lot of criteria to be on active surveillance. Not everybody agrees on that criteria. Why part of that criteria is not to universally offer germline testing? Nobody's ever going to convince me, I'm sorry to say, as to why everyone's not getting it if they want to be on active surveillance. Look, if your germline testing says you have this variant, BRCA2, and you still want to be on it and someone wants to follow you, great. But at least you have that extra knowledge. I thought that's what active surveillance was about. PSA density, getting the volume, PSA kinetics, doing some genetics. I thought all this was about more information and then making the right decision. So I don't know if you have one more word. I just will never understand why everyone in active surveillance isn't getting it. That's all I have to say.
So I'm an information geek. So the more information, the merrier, because I think that makes decision-making better. I think the more knowledge you have, the more powerful and informative your decisions are. So right. I, again, recognize that, there's a balance, and we certainly have to recognize that the national healthcare crisis and the cost. I get that, but we're still talking about relatively a very cheap test to help us make decisions.
So if I've got a small segment of Gleason 4, because now these intermediate guys on active surveillance, they got these small percentage of Gleason 4. Oh, yay, I can be on active surveillance. Good for you. That's great. Isn't that person more likely to have something show up on a genetic test?
So that risk goes to about 4 to 5% of the population, so higher.
Yes.
Once you get to higher volume Gleason 7, or certainly 4+3, that goes to just under, at least in our series, about 10 to 12%. So again, it increases. So, and again, if you're one of those, it's very impactful. But certainly, I think most people would say, well, I don't. 3+4, it's a gray zone area anyway. So if you have a piece of data showing that those people are really a lot more likely to progress, that's going to push you over. That's going to tip you to say, let's not monkey around here.
What if I have some of these different types of variants in the pathology? I have introductal, I have cribriform pattern, large type. These are more likely to have a variant that would show up on a germline test, right?
Yeah, so it's also a moving target because it's called a lot more by the pathologists these days. But
Yeah.
intraductal is still, or at least at one point, was part of the guidelines to consider testing because there was a higher number of patients in 2 studies out of the West Coast showing that there increased likelihood of a BRCA type mutation. The other warning I'll say is anecdotally, but supported by some of the evidence from in the literature, that a lot of these patients, while we always think that prostate cancer is the snail, the slow growing one, we always have a huge amount of lead time. We still have lead time, but if you harbor one of these type of mutations, specifically in one of those 5 genes I talked about, the chance of you going from 0 to 60 without a lot of signal or change in your PSA or ancillary type test is high. So a lot of changes happen kind of underneath the cancer, so that when you check it, even a year later, you're like, holy cow, we missed something here. And that's where I've, again, try not to use anecdotal data, but that's where I've been burned several times, or again, without that knowledge initially, that those mutation patients are a little bit more sensitive.
Well, if active surveillance was 100% accurate, if surgery was 100% accurate, radiation, focal therapy was, we didn't have, you can always work on the recurrence rates to lower those recurrence rates. Well, maybe one of the ways you lower the recurrence rates is you catch the disease truly earlier or figure out which one's aggressive, which takes it back to germline testing. So I appreciate this today, Brian. I went from 99.999 repeating that everyone should get a germline test when they're diagnosed to 100% thanks to you, even though I know that was not your intention. Now let me bring up the NCC, the big guidelines. And look, this is a respectable group. They're an incredible group. No one's not saying that they're not an authoritative group. They're saying, tell me which ones, if anything's changed. They're saying you should get germline testing if you have a personal history of aggressive prostate cancer, a family history. I think that's one of my favorite. Intermediate risk, so you have introductal or cribriform, a history of cancer. And then they put, so even if you get a germline, you should get at least all of these tested. Do you agree? So this is the latest list. BRCA 1, 2, HOXB13, which is specific to prostate, like you said, ATM. Is this list, are we adding to this list, or should there be more on this list? What do you think?
Again, it depends on the setting. And that's what my big problem with NCCN for this recommendations are. It's taking a huge panel and narrowing it down to 11 to 14 genes. Not all of them are implicated in prostate cancer susceptibility. Not all of them are implicated in forming aggressive tumors. And HOXB13 doesn't form aggressive prostate cancer. It forms prostate tumors, including aggressive forms, but doesn't differentiate. So it is one of those, we have to understand what we're doing. And when we move into the advanced setting, and we're now starting to look and say, well, do you pair up with a chemotherapy? Why do we want such a small panel? What, don't we want the 150 genes that are included in the DNA repair, gene panel? Isn't that more appropriate to look at? So that's really where I advocate to say, we don't want to share all the information at once because it gets confusing, and I understand that. On the other hand, is having that in our locker and saying, hey, at some point, if you become metastatic and we start needing these chemotherapies, why don't we call up that list and say, hey, what do you match up with? Because it's not going to change. It's germline, and we have now ability, and that makes it a little bit more systematic.
A couple other things on this topic, and okay, I'm going to put away these NCCN. Not that these guidelines aren't great. It's just that I looked at this recent study. I should have provided the reference. I blew it. Some of these obstacles to genetic testing were cost, but like you said, germline is only running about $250. Lack of genetic counselors. I don't know if you want to comment when I'm done with this. Lack of healthcare professional knowledge and confusion. People admitted that we don't know. We're not Brian Helfand, so we don't know what the Helfand is going on here, So, and then health disparities, race, SES, socioeconomic status. So again, if these are all obstacles to genetic testing, can you please, I don't know if you want to add to it, explain to me why people don't get germline testing?
Right. I mean, I think they're all obstacles, and I think we still have a long way to go. I think we always have to adapt to technologies. We always have to adapt to new information. I do advocate that it's worthwhile for most urologists, treating clinicians, et cetera, familiarize yourself with the basics of genetic testing and what we're really looking for. Yes, certainly, I think we have collaborations with genetic counselors. They're a very, very important part of this whole experience and counseling. And I think we can make it easier on genetic counselors if they are limited in your area by doing some of that initial discussion of saying, what are the risks and benefits of genetic testing? What are we looking for? What are VUS, things like that. But we can start informing patients of the reason, the rationale, the potential harms and benefits of testing ahead of time. Order that genetic test. And certainly if someone comes back positive, those are the patients that you're going to refer over for additional kind of counseling on other non-urologic type of diseases. Because again, I think as a urologist, we're very well positioned to counsel on the implications of these mutations in urology, but all the other things, the screening for melanoma, pancreas, get them over there and they'll kind of sort them out. I do think for the shortage of genetic counselors, a lot of these companies, whether it's Ambry, whether it's GoPath, whether Invitae and other companies kind of to and fro, they do provide genetic counselors as a service that you don't have to pay for. That's part of that genetic counselors. They do have things like bots, so computer generated programs that kind of talk you through a lot of that initial and post testing counseling. So I think that can certainly be overcome, and certainly in the era of telemedicine, all of this can really be done virtually. So
that's a good point.
Becoming a lot more prominent. I do think that educating physicians and now patients is, kind of also at the crux, and we shouldn't be intimidated. We shouldn't go to sleep when we hear genetics, but rather embrace it, because I do think that increasingly it's going to become a part of the journey for prostate cancer, but so many other, cardiovascular disease, all that kind of stuff is really going to invoke or at least involve a lot of the genetic testing.
I think it's interesting that we're running around with all these PET CTs and PSMAs and all these different molecules, and they're changing the staging game. We really don't have long-term data on them in terms of how much they're going to change it, but everybody agrees, oh, let's get that done. It's the latest in technology, but we can't come to an agreement on genetics? Anyway, all right.
We all think that we can interpret a picture, right? So when you show an image, you're like, I got it. When you show a piece of data, and a lot of the reports that are generated make it easy to look and understand the genetics, what to do based on where you are in the prostate cancer journey. But we need to still overcome that.
Thank you, because Brian, genetics is also a picture. It's a piece of the puzzle that adds to your puzzle in general that helps clarify your picture. You need the piece when you need. I'm not even a big fan of aggressive testing in public health, but with genetics and being diagnosed and active surveillance, okay, now I'm going to bring up something. Now we're going to get into the meat and potatoes as we finish it off, okay? Wait, that might not be PC in today's world. We're going to get into the beans and kale. All right, let's get into the beans and kale. See, I'm just the trend center, baby. All right, so I'm going to bring up something that you haven't talked about in your talk, and I understand why you haven't. You've talked about it with doctors, but I want to talk about it to show you again why I believe your talk is so relevant to everybody watching this. Let's talk about a syndrome, which I had no idea until I knew you were speaking, that can occur in every 1 out of 300 people, and that's called Lynch syndrome. Lynch syndrome. So Lynch syndrome is another one of the most common hereditary forms, well, the most common hereditary form of colorectal cancer, I guess. And you can explain it better than I can, but the genetic test that you're calling for can also identify whether or not you may have this Lynch syndrome, which is actually a lot more common than people believe, because we now believe that some people with Lynch syndrome might have a higher risk for prostate cancer and aggressive prostate cancer. And I'm done talking. Tell us about Lynch syndrome.
Right. So again, our knowledge continues to expand, and certainly when we think about the prototypical type genes, everyone says, "I know BRCA genes, therefore I know everything." Well, there's a lot more relevant genes in there, and so there's a class of genes known as mismatch repair genes, yada yada yada. That again confuses people. Who cares what they are? I do, but it doesn't make a difference. But these are genes like MSH1, MSH2, MHH6, and there's a whole series of those genes. And if you have mutations in those genes, statistically, you're still most likely to develop colon polyps. And the Henry Lynch is the guy who really identified that association between Lynch syndrome and these polyps, and helped really lead to the identification of many of these gene mutations that predispose to it. And so certainly what we've recognized is, hey, a lot of these guys who have colon cancer are also getting prostate cancer, and some of them are even kind of lethal, aggressive forms of it. So we, as well as others throughout the world, did a study of these type of patients. These looked at Lynch syndrome patients. We kind of piggybacked that onto other mutation carriers who had BRCA too, et cetera. So we included them as part of a subset of the study. And we found that men who had mutations in MSH2, MSH6, were significantly more likely to not only develop prostate cancer, but really aggressive tumors. So it is, something that really excites us, because again, it's another, area that we should be screening them differently. But certainly the other exciting part about these is that if you did have a mutation in them, you may be more, and you had advanced prostate cancer, you may be more susceptible to immunotherapies. These are a different category of drug therapies, if you will, immunomodulation, that excite the immune system and help you treat your aggressive prostate tumor. Other part about this is that if you do somatic testing, one of the things that they now look for are something they call MSI, or microsatellite instability. That is also a mumble jumble. But what that is that they can take a tumor and they can look at the length of certain parts of the DNA. And basically, based on that signature, they can call people that are tumors that have a lot of this microsatellite instability, or MSI. They can call them MSI high or MSI low, meaning they have a lot or little of this type of DNA signature. And if you're MSI high, you have a significantly increased likelihood of harboring one of these mutations. So a lot of them are now, as part of the normal somatic testing, looking for that, and then going back and doing both germline and somatic testing for the other, for these mismatch repair genes.
So I just think it's interesting. The NCA, to all fairness to NCCN, if you look at they're asking you to pick up on some of these Lynch syndrome mutations. So Lynch syndrome is supposed to be a part of everyone's vernacular, but why aren't we talking about it more? So Lynch syndrome, if an active surveillance patient ends up having one of these mutations and has Lynch syndrome, do we know enough now to say maybe you should be treated or not?
It is one of those where it's very rare. Even among the mutations, it's very rare. So it takes a lot of patients to really get the data. In our series that we collaborate again with our institution and Johns Hopkins, it does appear that they may have a higher likelihood of progressing on active surveillance. So again, we put high caution there, but it's going to take years to get enough of those in active surveillance to actually monitor that. The other caution that I put out, because it is urology, and this is a urology fan base here, is that Lynch syndrome is also highly associated with tumors in the upper tract, so in your kidneys, in the tubes of the kidneys, and bladder. And so again, there's not a formal or recommended screening protocol, but certainly if those patients have blood in the urine, they should definitely take that seriously.
It's incredible to me. If you look at the company you advise for, other companies, and you look at the panel, the prostate panel, everyone's got a prostate panel. It's different between different companies, but some of them are in full agreement. The BRCAs, the ATM, the CHEK2, and the Lynch syndrome stuff. It's like, come on, man, why aren't we? This just goes back to why I can't sleep at night. What kept me out of the good schools is why this just stuff makes me this wacky when I think about this. All right, couple more things before we jump completely and leave. I had to bring this in because I've never asked you this, and I've never seen anyone ask you it. So now I'm going to ask you it, and I want you to tell me if this is right or wrong. Okay. And this goes back to genetics. Do heart healthy lifestyle changes, the stuff that I advocate, right? Do you believe it delays or eliminates the risk of aggressive prostate cancer? In other words, the $1 million question that we are not, I think, explaining enough is, what am I doing if I'm taking care of myself and I haven't been diagnosed with aggressive prostate cancer, or even if I have been, is it possible that the lifestyle changes I'm making, dietary changes, exercise, you name it, all the things we love to talk about, can that actually change the expression of some genes? Because in breast cancer, the consensus is it's preliminary, but it does. So can you comment on being really healthy in terms of your lifestyle? Because look at you. When I saw you 2 years ago, you've dropped a little weight. You're working out before you do rounds. I mean, you're looking like you could be an international male model, not a urologist right now. I mean, you're looking really good. You're taking really good care of yourself. But the question doesn't come up enough. If I take care of myself, can I actually change my genes or change the expression of my genes? Or am I stuck with those genes the rest of my life?
It's really the beauty of germline testing. That is the beauty of and nothing is fatalistic. Meaning that just because you are born with a certain genetic load or predisposition to certain things, for many of the diseases that we're testing for, it doesn't mean that you have to get it, or it doesn't mean that if you get it, that it's the end of the world.
Right.
And that's really the point of screening, et cetera. But certainly lifestyle changes and lifestyle modification can exert powerful effects over this, right? So we do know, and Adam Keibel published a study on this out of the Boston system, showing that the polygenic risk score, which we know is associated with increased risk of prostate cancer, men who live healthy lifestyles, who eat heart healthy diets, who exercise, are at actually a slightly lower risk of being diagnosed with prostate cancer. So that's awesome, right? So if you take, and the only thing you do is change your lifestyle, you can modify what your genes are telling your body to do. So that modification and the influence is awesome and gives us a lot of hope. And that's why we set up screening programs to say, hey, if we know you're genetically at risk, let's be proactive. Let us get you involved in a lot of these programs. If we know that you have a genetic risk of heart disease, and this is now being incorporated into their guidelines, is if you have that genetic risk, go get on a statin, make sure you're getting screened, stay active. So we're trying to prevent that based on what the genes are. We can't control the genes. That's what makes us all special. But what we can control is the lifestyle that we're kind of given. And as a somewhat parlay of that is that, one of the things I talked about was the effect of hormone therapy. We're giving you a drug that's a modifier, and that's going to increase your risk of osteoporosis, depression, and cardiovascular disease. So in that way, the lifestyle is doing a disservice. But if we're aware that you have that predisposition, we can at least try to counter the effects of the hormone therapy ahead, proactively. And that's really so the environment is very powerful, good or bad.
Well, what I'm seeing in the literature lately, and again, I drink this Kool-Aid, so I want to believe it. I'm seeing in some cases, not all, and maybe even a minority of cases, that at least when you take care of yourself, besides having a better quality of life, the chances of a certain gene being expressed or rearing its ugly head, maybe later on, maybe not at all, increases in your favor, right? It's like androgen deprivation to me when you're doing, and you should let me know before we're done today when we're going to be able to test for this on a polygenic risk score in terms of side effects. But, you know, if you're already taking care of yourself and doing everything possible, you would agree that those side effects are much less severe in general when you take care of yourself versus when you don't. But we all want to predict who's got a higher rate of depression on hormone therapy, who's got a higher rate of osteoporosis. So you talked about that at the very end. Is this test ready for prime time? Are we looking at a year or two or what?
No, we can actually get it now. I mean, again, a lot of that polygenic risk scores for these are used for other diseases, right? I mean, for heart health, and our cardiologists order that test now. So it's just using that test in our favor because we are intentionally giving you a lifestyle modification, ADT, hormone therapy, that's inducing that risk. So we want to see who's at risk and use that as a signal to the dumb urologist like myself to say, that person's at risk. We're giving them a drug that's going to increase the likelihood of inciting that bad event. Let's stop it.
People get genetic tests all the time. And we got to admit, one of the problems, besides the cost, is they'll get, and I call this what the hell fan. You mentioned this. They get something that comes out in some kind of words that say gene variation of unknown significance. Not sure what this means. What the hell fan is that? I mean, like, what are you supposed to do with that? Because it's screaming at you on the report. The patient sees it. How do you, what do you tell patients when they get this?
Right. So we don't want to ignore them. And basically what a VUS is, or a variant of unknown significance, is understanding that our DNA and our sequencing is very complex. And there are so many different variations throughout everyone's DNA. Some of them have implications, meaning that if you have that variation or mutation, it causes the disease. And others, we don't really think so, based on where that variation is in a gene, that it's not really predicted to cause a problem. But nonetheless, most people don't have that variation, but does that cause the cancer? Probably not. So when you look statistically, if patients have this kind of unknown variation, we don't think it's a mutation, it's never been reported as a mutation, that ultimately we call it a VUS. And what that is that we look in and we say, well, how many VUSs are actually ever recategorized as pathogenic, meaning that they cause a cancer? Less than 10% of them. So 90+% chance that it's going to be recategorized at some point as benign. But usually when I see a VUS, I counsel patients and I say, hey, there is that possibility you could have that. Right now, we don't think so, and we should not act on it like you have a mutation. We should not act on a VUS like you have a mutation. We can send you over to genetic counseling for further discussion of it. But just so you know, is that there's a 90+% chance it's going to, at some point, the company is going to recontact you and say, you know what, it's benign, don't even think about it, done. I've actually had one ever that's been recategorized as positive. Most of them have been recategorized as negative.
So this is just, they kind of just scream at you, but they don't really have any hoopla behind it. It's just non-actionable. Okay.
They shouldn't get your heart rate going.
Okay, I love that. Here's another one. I'm in the world of OTC. I love, as you know, I love the world of OTC, over-the-counter medicine. I love when more medicines, I don't care, supplements, whatnot, that at least have evidence come and are available and people have control and they can get it if they want. The one thing that's making me nervous, and I don't want to get in trouble here in the OTC world, is there's a lot of testing going on over the counter. I know there's good companies and bad companies. What I don't think, and you have to tell me if I'm wrong, what I'm seeing is if you start doing BRCA and some of these other highly specialized tests over the counter, they'll be looking at maybe a handful or more of variants in BRCA. They won't be looking at the largest number that we have on file right now. In other words, not all BRCA tests are the same, is what I'm seeing. Some are high quality. Like I know that the company that you work with and other companies that you mentioned, they are high quality testing. They're really looking at the latest and greatest variants in BRCA. What worries me in all this talk of genetic testing is some of them over the counter don't have that expansive list. They're not looking at all of that. Can you put that in better words than I can? I think that that is an alarm that should be discussed with all of the audience.
It's not dissimilar to most things we do in medicine, right? I think most things we do in medicine, there's going to be some error, right? It's very rare in genetic testing that is something as a false positive, meaning that we called it a mutation. It's actually not a mutation. Most of the time we see it's something that was called benign that actually is a mutation that was missed. That happens very, very infrequently. There are a lot of public data sets. ClinVar is one of them that most people use, that you can actually check so when a company takes a gene, they sequence it from start to finish. And it lists off, if you will, the address, the sequence of that gene. And if they find a mutation in that, they can check with various public data sets and they say, yes, this is, or it's not. But there's also an art form to it. And there's also other databases they can be checking. And also they can do modeling of that protein based on that. So there's a lot of things that they can be doing behind the scenes. So not all companies are set up to really do that in a high quality fashion. Most companies out there are pretty good. They're pretty good. On the other hand is, yes, there is going to be some variability. I think if you go with some of the kind of more well-known commercial companies, you're never going to go wrong because they are really set up, and they actually are set up to advise on prostate cancer and the implications there versus other cancers, et cetera. But I again, as the cost of sequencing decreases, all these companies are kind of popping up a little bit.
Yeah.
So there should be some caution there, but for the most part, it's not going to be so variable between so many companies. And most of the companies that are offering these type of tests, have some pretty good reliability.
Yeah, this is one of the areas I think patients should go to the doctor they trust and say, hey, what's a company you recommend? Otherwise there's so many,
Right.
and they can say, well, do you have any conflict of interest? But at the same time, why do you think that's a good company? And where do you think I should go? And why do you go there? And I think that they would be happy with the answer, because most of the clinicians out there, I think, want to find the best company for the patients. I mean, okay. Okay, now we're leaving germline testing for good. For the most part, you can take off your seatbelt, and I want to throw in one more controversy. I got this text yesterday from a friend. If I get more of these texts from friends, I could start up a business answering this question. So there are all these somatic, I call them somatic, they're liquid biopsies. And they cost close to $1,000 right now. And you can get them even if you don't have cancer. Right? If you don't have cancer, the companies are saying, and some of the well-known companies like I do, they're saying, just give us a couple tubes of blood. We're going to look for fragments of DNA that could come from cancer, and we'll be able to tell you whether or not you got cancer before anybody else can, so you can act on it. So do you want to comment on these? Because I think this is interesting, but it's also scary. Do you want to comment on these new tests available where you can just submit some blood and then they can look at to see whether or not you have, 20 different types of cancer, and they think they can tell you early? How do you feel about these?
You don't ever want to be falsely assured by these tests, right? Because sometimes, and I've seen this, is people will obtain these tests. They don't have cancer. They had a negative signature. And then several months later, all of a sudden they are diagnosed with cancer. How is that possible? It's possible because tumors can form at various stages. And unless you're repeatedly tested with these, which again is not recommended at this time, although that's what they want you to do, that's one. Two is we have to understand that not every cancer is the same. And certainly prostate cancer, as an example, is very, very different than skin cancer or bladder cancer or kidney cancer, et cetera. And behaviorally, the ability of cancer cells not only to spread, but to shed cells and DNA into the bloodstream is also variable based on cancer type. And certain cancers, colon cancer, are potentially a little bit more amenable to tests like that because they do have a lot more DNA that's put into the bloodstream we can test. But things like prostate in general aren't the best at these type of assays. So they do typically offer a prostate test. The actual validity of them is called into question when we've delved into a lot of the signatures that they're looking at. In my opinion, for whatever that's worth, are not always the best, and certainly don't pick up most tumors, and certainly aggressive tumors, just because prostate cancer doesn't shed a lot of that DNA, and the DNA signatures they're looking at aren't the best. So I think it's a moving target. The concept is awesome, right? You can get a blood test, it tells you everything. Hey, I feel assured, I don't. But it always also has to be followed up by other testing. So if you test positive for colon cancer, you're always going to then go and undergo a colonoscopy, because that's the gold standard. And so it's not meant to replace any of it, it's to supplement it. But I don't think, in my, again, opinion here, it's really ready for prime time, and it should be really more in the experimental stage right now.
I appreciate that, because I see also a lot of criticism in the medical journals that one group in the UK said, look, until you can prove that you reduce the risk of dying of that cancer, you could be doing more harm than good. I thought it was I love the technology. It's incredible how many people now are hearing it. So I got friends from college going, hey, should I get this? Like I said, I got one yesterday, and I thought, I got to ask Brian. So I hate to even bring this up, but artificial intelligence, I mean, I'm not even sure what that means anymore. I mean, people are applying all sorts of definitions. Are you going to see it seems to me that if artificial intelligence is what I think it is, that it's going to have a role in all stages of prostate cancer pretty soon, because it's going to be boop, 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 boop. You type in a bunch of stuff and it outspits your statistics or what your probabilities are. How do you feel about artificial intelligence in prostate cancer? Is it going anywhere?
I love it. Actually, absolutely love it. I think there's a lot of potential. And I really think, number one, it's never going to replace being a physician. It's never going to replace touching a patient. It's never, but what I think it has the ability to do is take a lot of different pieces of data. And that includes genetics, that includes imaging, that includes serum, blood tests, you name it, lifestyle, et cetera. And I think it's going to have the ability to extract even a deeper level, a lot of things that can impact that, kind of outcome of that patient. So it has a better potential to analyze those mixed data sets, right? I think that some of the confusion by a lot of physicians currently are that we're really comfortable if all the arrows point a certain way. The patient has Gleason 8 cancer. They're a BRCA2 mutation carrier. They have MRI that's positive. Hey, that patient needs treatment. There's no question about it. But somehow, when we look and we say, well, we want all that data, but some point a certain way, other point another way, it's not aggressive on my MRI, but it is aggressive on my genetic. How do we reconcile that? That's where AI is going to, I think, help smooth it over, because I think it has the ability to make a little bit decision-making on complex data simpler.
Most important question of the day. Michigan plays Northwestern in football in 2023. This is hypothetical, 100 times. All right, just 100 times in 1 year. Like, this is a realistic question. How many of those games out of 100 does Michigan lose in the past 12 months? They play Northwestern.
No, that's not, it's just not a fair question, because
I put this into artificial intelligence.
It may be there. It may be there. But right now, I would say Michigan's winning every time. But
okay, that's interestingly enough, that's the right answer AI gave me.
But with the new stadium coming to Northwestern, you don't know, right?
I know, but plus, I'd be fair. Northwestern's a geek school, so maybe they're not the greatest athletes, but they end up being all the bosses. I have to answer to Northwestern graduates, they're the smart ones who maybe didn't get invited to the prom, but now they run the show. So cry me a river. Is there a question I did not ask you, which you wish I would have asked you, or anything like that? Anything you can think of?
I think the overwhelming thing I always like to leave people on is, don't get intimidated by genetics. The word turns people off. The concepts are actually quite simple. They'll help identify who your population most likely to experience an outcome is. That's all it's really doing. And so if you just think about it simply, everything else is easy.
Yeah, and remember, just keep like you did a good job. Keep it separate. Germline is what you were born with. First focus in on that. Do you need that test if you are worried about getting prostate cancer or another cancer, or you're in active surveillance, or you were just diagnosed or just treated? First have that discussion about germline. That was the point of all of this. And the other 2 points I want to make sure is your last slide had a QR code. Please remind the audience of what they can do with that QR code. And please remind the audience, if they want to come see you, are you still seeing patients? I mean, I know you're seeing patients, but do you have openings? Can people still come see you right now? And what's with the QR code?
Yes, I still see patients. I still see tons of men unaffected and affected with prostate cancer at various aspects, and always happy to, as you can probably tell, talk about genetic testing and its importance. In terms of genetic testing, if you want, again, the QR code leads you to a company that does have polygenic risk scores as part of their testing. It's right now one of the few that specifically have the polygenic risk scores, but also combine that with the rare pathogenic mutations. And again, it's divided into the patient journey. So the report, when they generated it, looks at where that patient is along it, whether it's unaffected, newly diagnosed, metastatic, et cetera, and hopefully explains it in more understandable terms. So again, it's there as an option. There are research opportunities, I think, that are also part of that. And certainly, I think it's kind of a cool test. And I wish I could say that I had stock or benefited in some way. But it is really just was an advisor to help do that really for patients along that journey.
That's awesome. And you and I talked about it. You know, you do a type of BPH procedure that needs to get a little bit more attention in terms of the pros and cons. It's very popular. And you and I will be talking about that next time, and possibly the next conference. Isn't that correct? I'm just putting you on the spot, so you say
there
yes.
we go. Yes, I will be.
Okay. Now we got you a gift, because money's no object of the PCRI when it comes to giving gifts to our best speakers. So if we miss a mortgage, we miss a mortgage. That's the way it goes. So there's a gift arriving at your house today, according to what Alex tells me. So Peter, Alex, can you bring up the gift that is arriving at his house today? It's a cup that says, "I love DNA." I swear that's the truth. You're getting a coffee cup that says, "I love DNA." Now, has anyone ever given you such a gift?
I have not had such a gift. I have not. I have one that says "I love prostates," which is also equally as nerdy, but I love it.
Everyone loves prostates, man. But I love DNA. Good. So that says it's slated to arrive today at your house, Brian. Without sounding like an Oscar speech, that was a powerhouse lecture. It was great Q&A. You're a pleasure to be with. I think I love the fact that you help explain such a tough topic so easily. And I just appreciate your availability and your kindness. And thanks for doing what you do. I really appreciate it.
Well, thank you and the PCRI. I truly love these things. So hopefully we change some people today.
I think so. At least we got good objective information in there. Thanks again.
Thank you.